So week 7 is all about endocrine. It's all about cerebral. And I think through a Kahoots with concepts, I can describe what you need to understand. And then, as I do the questions, you don't understand, just let me know. Stop me, and I will answer to the best of my ability. So let's go ahead and do our Kahoots. Oh, there it is. All right, let's get going. Week 7, cerebral and endocrine. Great topic to do on a Kahoots. I really make it simple for you. Growth hormone is administered by what root? Now, the pituitary gland secretes a hormone, and it helps you grow. And sometimes the family's tall and the kid's short, so they want the kid to catch up. So they give this hormone, sometimes daily, sometimes weekly, depending on the physician, all the way until they stop growing less than 1 inch a year. And it's subcutaneous. So it's like giving an insulin injection. So these children, many of them learn because these are your 10 to 12-year-olds, okay, when we start to give these growth hormones, and they start to learn and give it themselves. It really requires a lot of sacrifice from the parents and the child. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. We are like, oh my God, what a word. Let's break it down. Antidiuretic, against urinating, against diuresing hormone. That means you're not urinating, right? So when you're talking about fluid balance, it's always in children, intake, output, and of course, daily weights. Always daily weights will be left in there. So if you are retaining fluids, what would you worry about? Well, you're going to restrict fluids and you're going to put them on a low sodium diet so we can correct this, right? So think about those things. Fluid balance, what do I do with it? Too much, too little. Which of the following are signs of the syndrome of inappropriate antidiuretic hormone? So when you have antidiuretic against diuresing hormone, you're retaining fluids, you're going to have a decreased urine output. Very good. And remember, older people, even child with, cardiac conditions, they're going to fill up. They're going to be in congestive heart failure. They're going to have peripheral edema. You're going to see it. What is important to cover when teaching the family about prolififacil? It's also called PTU. And this is a medication given for hyperthyroidism. But there's a specific thing about this drug that this family needs to know about as a side effect. So it's hyperthyroidism. It causes leukopenia. So one of the things that happen, they may see, is they're going to run fevers. Like, ever hear of a drug fever? This is one of them that you'll see. And then, of course, sore throat. So is it a real upper respiratory or viral infection, or is it something to do with the drug? What do we tell these patients to do? Call their physician when they're having fever or sore throat. It could be the drug. I'll multi-select. An initial sign of diabetes insipidus. Opposite from syndrome of inappropriate antidiuretic hormone is diabetes insipidus. The posterior pituitary secretes too much hormone. And it's only two things. DI is only two. And it's polyuria, polydipsia. Polyphagia, or you're hungry, is only with DKA and with diabetes, okay? So when you're thinking diabetes insipidus, it's all about fluid. That means I'm thirsty, urinate, urinate. And we sometimes figure out how to diagnose a newborn is if they're eating all this formula or breast milk and it's not satisfying them, and you see them urinating, you give them a bottle of water and they're satisfied and they're quiet. And you're like, okay, this has to do with diabetes insipidus. I'll multi-select. What are the clinical manifestations of juvenile hypothyroidism? Now, hypothyroidism in adults and children are the same, except for one thing. We know the hormone, the thyroid hormone, is very important for children, newborns for cognition, and we also need it for the growth. So they grow, we need it in their body. Now, some of the times you'll see dry skin, thinning, or like the sparse hair, like they don't have the normal full head of hair like you would see in a normal child. And of course, constipation, cold intolerance, all of the things you see with adults. And then just add on decreased growth because they don't have the hormone to grow properly. And infants, cognition will be delayed without that hormone. A child has had a simple febrile seizure. What education would you provide to the parents? Now, it really doesn't matter if they're having febrile seizures or that tonic-clonic foaming at the mouth going unconscious seizure. This is teaching education that must be given to the parents and to the family. They have to know how to take care of their child during one of these moments. So this is all about safety, 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 safety. Now, febrile seizures are usually in children 6 months to 6 years. They grow out of it. My firstborn grandson had febrile seizures. His mother became a fanatic of every day taking his temperature 20 times because she wanted to give him something quick because she never wanted to see it again. And it really becomes, this overwhelming thing. But just teaching them, turning them on their side in case they vomit, clear the bed of any sharp objects so they don't hurt themselves, put the head of the bed down, and then pad the side rails. And of course, monitor it, what time it started, and call the safety team. That is our job in a hospital for a seizure, okay? And we just teach the parents, have the environment safe on their side. And then, of course, monitor the time so they can tell the physician what happened. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? I mean, this is when we think of seizures, what we think of as a seizure in a child. These are your tonic-clonic ones. Very good. Again, what are we teaching the parents? Same thing. Turn them on their side in case they vomit. Protect, the environment. Remove any sharp objects. Pad side rails, head rail, bed down, and then of course call the rescue team just in case. What notable sign may indicate increased intracranial pressure in an infant? Well, an infant cannot tell you that they have a headache, which would be increased intracranial pressure, right? But there's two different things you could see. But this one's asking for one. You can walk into a room of crying infants and you hear a child with increased pressure in their heads. It is this high-pitched nails on a chalkboard. You'll never forget it. And you'll say, oh, that's the neuro kid. You can hear it. Also, remember fontanelles at rest will be bulging, not crying. All infants crying, the fontanelles bulge. But if they're quiet, relaxed, sleeping, it's bulge, that's increased intracranial pressure and that high-pitched cry. All of the following increase intracranial pressure except what? Working with these children, whether you're in the PD ICU or floors, and that they have, problems, head injuries, we need to know what's going to increase that pressure, because we don't want to do it or do it as infrequently as possible. Now, heart rate has no demands on intracranial pressure, it has nothing to do with it, but you're touching them, turning them, they're coughing, and even sometimes they're intubated. So suctioning should be once a day, once a shift, just to clear the endotracheal tube, because we don't want to overdo it and increase pressure. It could cause bleeding. What findings can alert you to a head injury getting worse? Many times we have a lot of sports injuries coming into the hospital where they hit the knee of a defender sliding into third base and they were rendered unconscious. The thing is, they'll keep saying, so was I safe? So was I safe? Or did I win the game? Did I win the game? And you're going to see this repeatedly. So that's the first change in mentation that you'll see with a head injury. Also, headaches getting worse, and also vomiting that has no correlation with eating. So they start to vomit more, headaches getting worse, you have an increased head injury going on. What does it mean when you see a fixed and dilated pupil after a head injury? Now, this is one thing that nurses and physicians do when we know there's a head injury. We'll look at pupils to see what's going on. Because sometimes there's no coming back from a fixed and dilated pupil. Because the fixed and dilated pupil means your brainstem is being squished upon and it's damaged and you can't change it. It's like nothing you can come back from, okay? It's irreversible. This is a true and real neurological emergency. They need to release that pressure in that brain as soon as they can. So if you have a child coming in like this, they need to have surgery as quick as they can. What are the following signs and symptoms are more common in children than adults following a head injury? Now, my grandson last weekend had a big old bruise on his forehead, fell off my bicycle onto a cement floor, and had this big knot. I'm like, I don't believe you just did that. But what you see is these children, when you know a head injury is causing problems, they'll be nauseous and they'll vomit. Adults don't. Rarely do they. They'll have the headache, but they're not going to have that nausea and vomiting. Children will vomit, not adults, usually. What medication can be used for a child with cerebral edema due to a fall? So, swelling in the brain. You need to release that fluid. What diuretic is specific to the brain? That's the way you have to think about that. And it's mannitol. Furosemide is congestive heart failure, peripheral edema, but mannitol, it's specific for the brain, renal failure, and toxic ingestion, but it's for the head. Reye syndrome, what is it? Excuse me. So Reye syndrome has to do with taking aspirin, and you have this metabolic disorder in children. The only time we give aspirin to a children is Kawasaki disease, right? The aspirin prevents clots, it thins the blood, it's used as an anticoagulant. and an anti-inflammatory. Febrile seizures usually occur in, what did I tell you? These are usually about 6 months to 6 years and they grow out of it. And they're seizures. They still need to be protected. You know, the environment, turning to the side, and also monitoring the times of them. You know, a parent's going to ask you, so my kid's had a febrile seizure. Does that mean he has epilepsy? No, one seizure does not make epilepsy. It's that frequency of seizures which could cause epilepsy. Childhood hypopituitarism results in which condition? Remember, there's that growth hormone, right? We give it in a subcutaneous injection for those with the pituitary glands not giving you what you need. But sometimes there's a complete absence, and that's called pituitary dwarfism. How would you describe precocious puberty? Well, we know what puberty is, but what is precocious? So precocious puberty is when you reach puberty early. They say Caucasians is girls age 7 and African American age 6. And there is something called Lupron we can give that can stop puberty from happening until about when it should. And they say normal is 12 years and 4 months, okay? But it can also go to boys. So girls will get boobies, but boys will get facial hair. So we do need to not let an 8-year-old boy have a beard. I mean, because that what would happen. A multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? This is knowing your lab values, what they're used for, what to look for. You know, as a nurse, you have a chart, you have all of this information. How do I read it? T3, T4, TSH. Those are all thyroid. Growth hormone is pituitary, and cortisol is adrenal gland. Okay. Knowing what is what, very important. How can you monitor a child with hypo or hyperthyroidism? Remember, this has to do with growth, right? Whether it's a pituitary dwarfism or if it's too much, it could be the hypothyroid is, you know, used for things. It's always pituitary growth, too much, too little, too big, or thyroid, which works with growth. It's always height and weight. Why do you think we do that every visit? Every visit, ER, doctor's office, urgent care, it don't matter. We're going to be monitoring that. We can see, is the growth hormone working? How's the thyroid medicine doing? We could do all those things with just that. What acid-base alteration would you see in a diabetic child with Kussmaul respiration? Well, Kussmaul respiration is due to diabetic ketoacidosis. This is a child who has metabolic acidosis. Kussmaul is trying to compensate. So if it's metabolic, Kussmaul is respiratory, and it's alkalosis. It's opposite. So it's trying to compensate for metabolic acidosis. Does that make sense? It's opposite. A multi-select. What would a child with Cushing syndrome look like? Now, Cushing's syndrome is because of too much steroids. What happens is they gain weight. They've got red, ruddy cheeks. They've got pendulous abdomen. They've got hair where they shouldn't have hair. And then their extremities are skinny because it's all in the abdomen and the face. Remember, I talked about children with cancer that we need to give them bigger jammies so they don't be sitting there feeling tight in their clothes because they get very subconscious about Cushing's syndrome. How do we stop Cushing's syndrome? Well, if we're giving them too much steroids, we need to taper it off slowly. A multi-select. You walk into a child's room with a fever of 104.6. You see them having a seizure. What do? What did I tell you we teach? So check the objects in the bed that can hurt them, side rails up, pad, turn them to the side. Now, the only time we give a cool water bath if it's hyperthermia due to being like in a car and their temperature's up because of heat, never because of a seizure. An autoimmune disease of the thyroid gland. This is usually females, adolescents, and it requires frequent lab values to be done, medication to be taken every morning. And this is something that you can't take the thyroid gland out. It has to stay there. So it is called Hashimoto disease, okay? My daughter-in-law has it, and she's chronically looking at her lab values, changing her medications and doses to get it in the proper, whatever works the best. Addison's disease. Well, Addison's disease is opposite from Cushing's. It has to do with adrenal glands. What do the adrenal glands do? And if you don't have enough, it's that decreased secretion of cortisol and aldosterone. You'll see this with children born that have ambiguous genitalia. We don't know if they're boys or girls. Their adrenal gland didn't secrete enough cortisol and aldosterone, and they're going to need supplements for life. I'll multi-select. Ventricular peritoneal shunt. Now we're talking about increased intracranial pressure. We're talking about too much fluid on the brain. The brain doesn't drain it properly. We need to put a catheter in the fourth ventricle, goes behind the ear and has a little pump there, and it goes into the peritoneum. And what we do is we just drain fluid. It is used for hydrocephalus. Now, that pump that's behind the ear is only for the neurosurgeon. We're never to touch it. Our nursing care of a child with a ventricular peritoneal shunt is to do a head circumference every shift. Is it getting bigger or smaller? And looking at their fontanelle, seeing what it looks at. That's it, okay? That was a question on the HESI I've seen before. A common size of Graves' disease include blank or protrusion of the eyes. Graves' disease is hyperthyroidism. Exophthalmos, eyeballs are out of the head and has to do with hyperthyroidism. Most people that you see their eyes bulging out, it is hyperthyroidism. A multi-select. Hypoparathyroidism has the symptoms of tetanic muscle contractions and blank. There's a difference. It has nothing to do with the thyroid gland. It's called a parathyroid because it's next to it. When you hear the word tetanic, you think of muscle and contractions, right? What electrolytes affect your muscle contraction, calcium and magnesium, right? So this is all about low calcium. The parathyroid regulates calcium levels. If you don't have enough calcium, you have very weak, technic, like non-working muscles. And then if you have too much, there's going to be more spasm of the muscles, right? Probably even some numbness in the hands and the feet because of it. I'll multi-select. What are the signs of hyperparathyroidism? Too much calcium. One of the things with too much calcium is that nausea, vomiting, and then you get really confused with it. And of course, that numbness of the extremities, because there's such tense muscles going on, you're not getting the blood flow down there. So they get this paresthesia. What does the parathyroid hormone do? After those questions, what is it all about? It's all about calcium. Calcium, calcium, calcium. If you don't have enough calcium in your body, you're going to have really weak bones. Which of the following might be a cause of an adrenal crisis or an Addisonian crisis? You know, in pharmacology, they tell you if you're giving steroids, you need to taper them off. If you have this child or adult on high dose steroids and you just stop them after a month on them, they're going to go into an adrenal crisis. They have to be tapered off very, very slowly to prevent that. I'll multi-select. A cardinal sign of diabetes insipidus. I'm re-asking you, see if you know it, because this is one of the most common errors students do on quizzes and exams and HESI, this question. So it's di, which is only two, polydipsia, polyuria. It's not polyphagia. They're not hungry. That's only to do with diabetes, regular diabetes mellitus, okay? Has nothing to do with diabetes insipidus. Diabetes insipidus, you drink too much, you urinate too much, and you regulate it by low salt diet, and steroids will help cure this up. And nursing care, INO, daily weights. And we're going to regulate the fluid and salt intake. Multi-select. Congenital hypoplasia parent teaching should include. This is that low adrenal. This is that ambiguous genitalia that occurs. They'll need cortisol and aldosterone treatment for life. I've only seen one of these in my career. And it was a little girl who had testicles and a vagina. So they had to determine, what do we make this child? So they did ultrasounds, they did hormone testings, and they made the child into a girl. Now, that's why there's a lot of confusion going on today, I believe, at times. But the thing about these children, number one, they're going to need replacements for life. You need to determine, are they a boy or a girl? But they'll never be able to have children. They don't have all the body parts. Whether you change them to boy or girl, they just don't have all the parts. That's a really hard thing to work with parents with. What causes type 1 diabetes? Bob has 36 candy bars, he eats 29. What does he have now? Diabetes. I love that one. I had to put that there for y'all. I know it's late. You can't laugh. I get it. Diabetes is when the body attacks its beta cells in the pancreas. Just simply as that. If you don't have the cells to produce insulin, my body is like saying, yeah, I don't want you around, and gets rid of them. So now you have no insulin. What does insulin do? Well, it eats and makes sugar into a workable type of component for you to be able to ingest and to work with. So it takes the carbohydrates. Now, when you don't have carbohydrates because you have no insulin, what does the body say? It says, I'm hungry. So what does the body do then? It says, well, there's other types of food. There's proteins, there's fats. Well, let me go eat some proteins. So what is a byproduct of protein ingestion? Ketones. That's when you go into diabetic ketoacidosis. What statement about a pheochromocytoma is correct? This is a tumor that grows off the kidney adrenal glands. Very hard to detect, very hard. This child, this adult who has this could end up having cardiac 24-hour monitors, all sorts of cardiac stuff going on, and trying to figure out what's making the heart speed up intermittently, blood pressures go up intermittently. It's this catecholamine that's released, and it's a sympathetic type drug like epinephrine. Heart rate up, blood pressure up, that nervous, that tightness in the chest. That's what it produces. Now, once we determine what it is, we can remove it, but it's finding it. So if you were a nurse, knowing they were pre-op with a pheochromocytoma, what are you going to look for? What is your nursing care? And that's this question. What action should the nurse implement in the care of a patient with a pheochromocytoma? You know they have it. How are you going to monitor it? Remember, it's sympathetic. It's like epi, heart rate up, blood pressure up. We're going to monitor vital signs. Simply heart rate and blood pressure, because those are the two things that are elevated with these sort of drugs. Multi-select. Nursing care of the unconscious child include. And in this case, unconscious child, adult, doesn't matter. You're going to do the same things. We're going to check neurochecks. We're going to check vital signs. We're going to monitor I&O. Remember, an unconscious child probably has some sort of swelling in the brain. We don't want to overload with fluid, so intake and output's important. We will monitor pain, but the other points are more important. Symptoms of DKA are. So remember, you don't have insulin. The body can't eat sugar. It says, I'm hungry. Starts eating protein, right? Protein byproduct is ketones. What do you see? All of the above. Now, the fruity breath smells like a rotten peach. Sweet, but rotten. I've put these children in a room and you close the door, and then a nurse walks in and it's like, oh, this is DKA. These children are pale, they're a little lethargic, they don't feel well. They usually are wheeled in a wheelchair. And these are older children that I see it in. And you will see excessive hyperglycemia. I've seen over 1,000 blood sugar. And then ketonuria 4+. And I've also seen the pH at 6.8. And the kid made it. It's just recognizing, what do we do first in DKA? Well, we need to give fluids, normal saline. They don't need sugar. They're already too much sugar. So we give salines and start a regular insulin drip so that we get that blood sugar down. And then everything else will correct and the pH will come up. And then, of course, we are monitoring the electrolytes as we do this also. Another multi-select. An adolescent has a BMI above 95%, has been urinating a lot. What test can you anticipate doing on this child? What do you think it could be? What do you need to rule out? So do a urine just to make sure it's not a urinary tract. We're going to do a hemoglobin A1C for sure. Sounds like diabetes to me. And of course, urinating a lot, you're going to lose potassium. So yes, we'll be monitoring electrolytes. Very good. Diabetic ketoacidosis is caused by what? I've explained it already 3 times. What do you see in diabetic ketoacidosis? Elevated blood sugars and ketones in the urine. So no insulin leads to the use of other fuels for energy. They go to proteins. Ketones are formed. So diabetic ketoacidosis. Another multi-select. A child admitted with a blood sugar greater than 600 large ketones. Priority intervention. What do you do? What do you know is going to happen? But what's the priority? IV, bolus of saline, and regular insulin drip. Now, we'll never give anything sub-Q when we have blood sugars like that. That just takes too long. We want it IV, and regular insulin is the only IV insulin. And then down the line, replace electrolytes. Priority, fluids, and insulin drip, regular insulin drip. A diabetic child complains of feeling jittery and the blood sugar is 45. What's the best treatment for this child? Now, patient condition always tells you what your treatment is. The child's complaining, so they're alert. I feel jittery, nurse. Do you have to give glucagon? Do you have to give an amp of D50? No. Just give him some orange juice and it works. Or even a glass of milk works too. Your patient has experienced a head injury. What would most concern you? Head injury, swelling in the brain. What could happen? Remember, there's all pieces of the puzzle in there. And remember that pituitary glands in there has to do with urinary output. That's what you're going to worry about. So decrease in urinary output. Excellent. Good job, guys. That was a hard one. A multi-select. How do you detect ketoacidosis? Diabetic ketoacidosis. Elevated blood sugars, ketones, and glucose. Excellent. Good job. Another multi-select. What would alert you that a child's head injury is deteriorating? So it's not that they become confused, they're already confused. But when they start getting to the point becoming restless, difficult to arouse, Headache is getting worse, waking them up from sleep. These are those things that you would say, okay? Complaining of a headache, they've already had a headache. It's going to get worse. A child's been diagnosed with bacterial meningitis. What is the nursing priority care? What's going to come next? What do you need to do for this child? Actually, what's the most important thing you should do for this child? Bacterial meningitis. You need antibiotics. Antibiotics. Give them as soon as you get them so that we can start treating what's causing, the inflammation of the meninges. What is the primary cause of injury associated with submersion? So the child drowns underwater. Many times they're up, somebody revives them, and they're running around by the time rescue comes. These children will be taken to the hospital because they could have respiratory distress syndrome up to 3 days later. It's because they have a lack of oxygen. Their lungs were full of water. They weren't breathing. The body didn't get oxygen. So the injury is hypoxia. And last question. I'll multi-select. What CSF lab values correlate with bacterial meningitis diagnosis? When I do taps, I look at them. Well, a milky, cloudy one, it's going to be bacterial, usually viral or clear. But then I want to see in the lab what comes back. Do they have white cells? Do they have protein? Do they have glucose? Well, bacteria love sugar, so it eats it up. Yum, yum, yum. So low glucose. It doesn't really mess with protein, so elevated protein. It'll be increased white blood cells. And actually, you should not have red blood cells in a tap, but sometimes they hit a little capillary. So you might see a couple cells. Let's see how we did today. Number 3. Yvette, good job, Yvette. Whoop, whoop. Sabrina, good job, Sabrina. And Chris, good job, Chris. Happy anniversary to my dad. Britt and Lindsay, good job, guys. Sign your attendance attestations. Don't forget it, please. And I'll be posting your grades momentarily. Let me go to the ladies' room first, and I will do that for you, okay? But all in all, good job, guys. Next week, remember, if you want to come to a class, I'm going to post what's up there and what professors. I teach Monday 3 to 5, 8 to 10, Tuesday 8 to 10. There are Tuesday afternoon and Wednesday afternoon classes. If you can hit one, do it. If not, I will post you a recording, okay? Good luck, guys.
Thank you.
Happy Thanksgiving.
You as well.
Thank you.
Thank you.
Happy
Thank you.
Thanksgiving.
Happy Thanksgiving.
Gobble, 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 gobble. Thank you.
You too. Bye.
Bye.